Hello, everyone. Today we have with us Dr. S.G. Kasi. Sir, welcome. Thank you so
Hi.
much for taking time out to be with us today. So,
Hi,
we
Dr.
all know Dr. Srinivas Kasi. Thank you, sir. It is indeed an honor for me to be officially introducing you, sir, though all of us know you. Dr. Kasi, sir, is a practicing pediatrician in Bangalore with a very special interest in vaccinology. Sir has been the past president of IAP Bangalore and he has been in the ACVIP as the convener, as the advisor. And I think we will be listening to Sir today discuss a lot of aspects of HPV vaccines and the burden of disease. So, welcome, sir. Today, let's talk about what exactly is we are there's a lot of talk about the HPV vaccine, but let's try to understand what exactly the disease burden is, sir. So can you please tell us something about this with special reference to India?
Okay, thank you, Dr. Sumitha, for inviting me to this particular session. Taking your question first, why are we talking so much about HPV today? Different reasons. The first one is HPV infections are extremely common, both in females and males. We must remember that HPV acquisition is something that occurs in almost 80% of all women through their lifetime. So it's not something that has something to do with your sexual behavior or anything. It's a natural acquisition that occurs. The second major issue is HPV is the only cause for cervical cancer. There is no other cancer which has a single etiological factor of a virus. So if we have a vaccine against HPV, we have the theoretical possibility of eliminating a certain type of cancer. Now, in this particular HPV, we have something called the high risk and the low risk serotypes. Now, the low risk serotypes are usually associated with genital warts, basically not life threatening, but something which definitely reduces the quality of life and increased healthcare utilization. Of course, we are more concerned with cervical cancer and other HPV related cancers. Now, coming to the burden, India accounts for 1/5 of the total burden of cervical cancer and the total number of deaths due to cervical cancer. About 115,000 odd cases every year, and somewhere about 63,000 deaths every year. And maybe a very vast majority of these illness and deaths can be prevented with HPV vaccination. So that justifies the interest and the discussion about HPV vaccine today.
You have so well elucidated the burden of disease, and as you mentioned, the numbers that we have, the morbidity as well as the mortality. But as we all know, we are in the absence of any kind of a registry. These are only the reported cases. Possibly there are many more cases which are going unreported. So in this situation,
actually, all this data has come from registries, but there are a lot which goes unreported. So most of the data that comes in is through registries in about 19 centers in our country. Of course, this will definitely be an underestimate of the actual burden.
Yes, sir. So as you mentioned, the virus and the cancer are definitely linked. So vaccination is a method of eliminating the disease going forward. So, sir, can you please tell us something about the vaccines?
Okay. It was way back about 24 or 25 years ago that the link between HPV and cervical cancer was established. And this was established by one scientist called Harzen, and he received the Nobel Prize for this particular demonstration of this particular link. And that formed the first basis for development of a vaccine against HPV. Right now, in our country, we have two vaccines. One is a 4-valent, which contains 4 HPV serotypes. The other one is the 9-valent, which contains 9-valent. Both these vaccines contain 6 and 11, which are basically non-oncogenic or the low risk types. HPV-4 contains 9 and 16 and 18, which are the major cancer causing strains. Now, 16 and 18 together globally account for about 70% of all cervical cancers. In our own country, it accounts for almost about 83.2%. If you take the 5 additional serotypes that are there in the nonavalent or 9-valent vaccine, the coverage in our country is expected to be around 98%. So that means it's almost totally prevents cervical cancer. Now, these vaccines are best given between 9 and 15 years of age. It's a little paradoxical that a disease which occurs in middle age, we are vaccinating so early. We must remember that there are certain reasons why we are vaccinating so early. The first is this is a prophylactic vaccine. That means this vaccine has to be given before the onset of sexual activity. That is the first point. The second important issue is that the number of doses reduces if you give earlier. The third point is that the immune response in those between 9 and 14 years have been found to be 10 to 100 times higher than what is observed in given when given beyond 15 or 20 years of age. And we must remember that we are giving this vaccine now. We expect protection to last over a very large period of time, long period of time. So high antibody titers are going to assure us that it's going to remain for a much longer period of time. All these are postulations, but now we have field efficacy trials from many countries, including good studies from Sweden and Denmark, which has very, very clearly showed that earlier the age of initiation of vaccination, better is its protective efficacy against cervical cancer. In fact, given the vaccine beyond 24 or 25 years of age has not had any public health impact on the incidence of cervical cancer. So the age of administration is extremely crucial, 9 to 14 years or 15 years. The next issue is about the schedules of the vaccine. Now, this vaccine, a lot of evolution of the number of doses have occurred. When the vaccine was first licensed for use, it was a 3-dose schedule throughout. Subsequently came the data that 2 doses in adolescents, young adolescents, is non-inferior immunologically to those given the vaccine at an older period. So 9 to 14 years, it came down to 2 doses. And now we are in the era of 1 dose. So presently the recommendation is that for girls, I'm talking about the recommendations in our country, India, for girls between 9 to 15 years, it's a single dose. For boys between 9 to 14 years, it is 2 doses still. Anyone above the age of 15 years or who have any immunocompromising conditions, the dose is uniform, 3 dose given is schedule of 0, 2 months and 6 months. When you're giving a 2-dose schedule, it's a schedule of 0 and 6 months. So this in very brief is about the vaccine.
Right, sir. Thank you so much for explaining all the entire concept of the vaccination, the age, the schedule, etc. So you mentioned about the vaccination for boys. So can you please, elaborate a little bit more on how the HPV vaccine is going to be useful for boys?
Thank you. This is again a very, very contemporary topic because even in our country now the recommendation has come for use in boys. Now, we must remember that HPV does not cause only cervical cancer. In women, it also causes vulvar and vaginal cancers. But in males, penile cancers, anal cancers, and oropharyngeal cancers. There is no reason why males should be denied the benefit of a vaccine which can prevent these cancers as well. That is the first point. The second issue is if you look at the epidemiology of HPV in males, there are certain peculiarities. One, in women, one natural infection confers around 32% protection against subsequent infections. Studies have shown that in males, one natural infection hardly confers any protection against subsequent infection. The second issue is the prevalence of HPV in the normal population in males is almost about 67%. Hmm? And especially in those who have spouses who have cervical cancer. In the general population, although it is lower, it has been found that almost one-fifth of them have the high risk HPV types. The third point is that while in females, the maximum acquisition is at the time of onset of sexual activity. Subsequently, it falls in a small spike between 40-44 years. On the other hand, in males, once acquisition begins, even till 45 years, the rate of acquisition goes on increasing. So, for all these reasons, there is no reason why this vaccine should not be offered to males as well. And lastly, I think the most important thing is where is the woman going to get that HPV from? It's from the males. You immunize the males, you're going to promote herd immunity and prevent transmission to females as well. So these are the various reasons why males also should receive the vaccine.
Right, sir. So I think, as you have rightly mentioned, it is currently a gender neutral vaccination.
Exactly.
Yes. So thank you so much for explaining this in detail to us, sir. Now, going forward, do we have data for the effectiveness now that since the vaccine has been rolled out? Do we really have effectiveness data? And is it? Probably it's a bit too early to see a fall in the cervical cancer cases. But can you please tell us something more about what is the data that we have?
Right. So, if you recollect, HPV vaccines were first licensed for use in 2010. So, we have 16 years data. It's not a small period.
Right.
I mean, enough data to even now show us that it works against cervical cancers. The first evidence that this vaccine works was against illnesses which have the shortest incubation period. Those are the external genital warts and extragenital lesions. And their studies have shown almost an 83% reduce over a period as short as 2 years. Subsequently, we have had data coming through two meta-analyses, one done about 10 years, one at the end of 10 years and the one at around 15 years. What it has uniformly shown is that the efficacy is greatest earlier the program is begun in the population and wider the coverage. And it has shown a very remarkable decrease in all clinical endpoints: cervical cancer, adenocarcinoma in situ, all the precancerous lesions, and including persistent infections. So now we have very robust data that even at the population level, these vaccines are working very well. In fact, Australia, which was the first country to adopt the HPV vaccine at the population level, is now targeting elimination of cervical cancer by 2030. I mean, it will create history. So there is no reason why other countries also should not be able to achieve this same endpoint. So this vaccine, enough data show that it works very, very well.
Thank you so much. That is so encouraging, sir. As you mentioned, Australia is looking at elimination of cancer. So we do hope that along the way we will also be, in the race to achieve the elimination as we are hoping. Sir, there has been, I mean, as we all know, a lot of talk about the downside of this vaccine. So would you like to say something on that, sir? The effects on the recipients.
Okay. Now, any vaccinee can encounter adverse effects after the vaccination. This association can be temporal, that is, it has occurred within a time period after the vaccination. It may or may not be related to the vaccine. The second is a causal relationship. Causal is where by established methods and protocols, you establish that that adverse effect was caused by the vaccine. Like any other vaccine, HPV can cause maybe temporally related to many adverse effects. Except for the common adverse effects like fever, pain, swelling, syncopal episode in adolescents, which is not to the vaccine but more, related to the age group at which you are administering the vaccine. No other adverse effect. Guillain-Barré syndrome or any other side effects like paroxysmal orthostatic tachycardia syndrome, chronic regional pain syndrome, primary infertility, all these have been very extensively evaluated and no causal link has been established with any of these suspected adverse effects. Yes, there are a lot of reports in the internet, unregulated reports, but all scientific studies have clearly shown no causal relationship. Putting it in a nutshell, it is as safe as any other vaccine that we are routinely using today. I think that is what we need to understand and believe in.
So thank you for explaining the causal, the temporal, and the causal effects of the vaccine. Also, specifically mentioning that there is absolutely no effect on the reproductive health of the
Yes.
recipient, because I think that, as you mentioned, the unregulated reports do highlight some such topics and points of discussion. So, thank you, sir, for giving us a concise overview of the HPV vaccine. And my final question, sir, what do you see? How do you see the road ahead in India, especially with relationship to this particular vaccine?
Yes. As you all aware, the government of India has rolled out the HPV vaccine. The vaccine being used is the MSD4 valent vaccine because India had received through Gavi a certain about 2 crore doses, and unless it lifted the stocks and utilized it, would have lapsed. So, right now, the government of India has introduced it to girls who are in their 15th year only. Subsequent to the utilization of all these doses, HPV vaccine will be used in the national immunization program. Now, fortunately, we have a Make in India vaccine, which is very, very less expensive compared to the imported vaccines. Although no decision has been taken, I do believe it's going to be a one dose schedule because more and more and more data is emerging that one dose is really good enough. Although the data is skewed towards females, we must remember that immunologically, males are non inferior to females. Of course, other aspects, let's forget about it, but at least immunologically. So, there is no reason why males should be treated differently. I don't envisage male vaccination so early. Maybe over a period of time, India may roll out the vaccine for females as well, for males as well. I think we are now in the right direction, maybe going a bit slowly, but we are definitely moving in the right direction. Thank you.
Much, sir. That was so encouraging, and it is so positive to hear it from you. All about the HPV vaccine, its uses, its benefits, and its safety. So, thank you so much, sir, for your valuable inputs and your time. Thank you, sir.
Thank you,
It's been
Sumitha.
a pleasure having you with us. Thank you,
Thank,
sir.
thank you. Thank
Thank,
you.
thank
Bye
you.
bye.
Thank you.
Thank you.
Thank you, sir. Bye, sir.
Thank you. Bye bye.
Thank you.